Okay, right. Doctor, so this is a 10 years, 7 months old boy. He has underlying bronchial asthma, which diagnosed at 5 years old.
Okay.
At the time, he has presented with cough, runny nose, and also difficult breathing. So, admitted for moderate exacerbation of asthma precipitated by URTI. After that, he was just discharged with MDI salbutamol, not started off fluticasone. And then after that, he has been given TCA, but he has defaulted his TCA follow-up. So subsequently, at 6 years old, he admitted again for severe exacerbation of asthma, requiring ICU admission. Highest oxygen was airborne. At that time, they given breast TCA, but he subsequently defaulted as well, doctor. Okay, so currently, he has total 3 previous admission for exacerbation of asthma. The last one was just recent last month in Hospital Kajang, which treated as severe exacerbation of asthma. Requires highest oxygen is hyponasil cannula and also IV Maxalf loading dose. Alright, so currently he is on MDI fluticasone 1 puff BB and also MDI salbutamol PRN as prescribed by Hospital Kajang. Mother claims is compliance to the medication, but she unsure whether compliance or not when the child was with father because the parents were separated. So total this is his 5th hospitalization. First admission at 1 year old where he has bronchiolitis, and then the subsequent 3 one was the one that I mentioned, doctor, for exacerbation of asthma since 5 years old, 6 years old, and 10 years old. So this time around, he presented with difficult breathing for 1 day. It started in the morning, and then mother was giving him MDI salbutamol 4 puff 1 to 2 hourly. So actually, they visited GP and was told the lungs was clear, discharged with flu and sore throat medication. So, but subsequently the SOB doesn't resolve. So hence she brought him to ED. And prior to that, he actually had sore throat for 2 days, and also starting to have chesty cough for 1 day, and also vomited 2 episodes. It was just food content, no blood, no virus, associated with mild epigastric pain, subsequently no more vomiting. So, and also reduced oral intake due to the sore throat, doctor. So, otherwise there is no fever, no runny nose, and then no loose stool as well. No history of foreign body ingestion, and then no history of new introduction of food as well. So, upon presentation to ED, sorry, doctor, I want to talk about the asthma history first.
So why do you think he was diagnosed asthma in the first place in Kajang? What are the history suggestive?
In Kajang?
Yeah, what are the history that point this patient have asthma? Just
in the first presentation, is it, doctor?
Just tell me all the history that you get.
In Kajang,
it's alright.
In Kajang, he has it's because the trigger is because he consumed large amount of ice cream. After that, he developed difficult breathing. Hence why sent to Hospital Kajang.
Alright, say more asthma history, class.
More asthma history. He has first nebulization at 2 years old. At that time was presented with wheezing triggered by URTI. And then the last nebulization was actually during the Hospital Kajang admission. So he actually had around 4 exacerbation last year with no hospitalization but required nebulization. The MDI usage was once every 2 weeks, usually was triggered by cold and URTI. So actually, mother claims there is no daytime or nocturnal symptoms. There is no exercise-induced symptoms as well. Only after swimming, he has cough, but mother attributed more to cold. So his trigger is URTI, cold weather, cold drinks, and cold food. So a bit about the personal atopy. He has underlying eczema and also allergic rhinitis, and also has multiple food allergy towards egg, milk, mango, and oranges. So family history-wise, sorry?
What happened?
What happened? He will have periorbital swelling and also periorbital swelling and
itchy.
Nasal congestion.
Okay.
So Family history-wise, father has allergic rhinitis. His elder sister, who is 14 years old, was diagnosed as bronchial asthma as well. Environmental-wise, he has a dog at home, which he usually play with, but there is no carpet, no smoking at home. So there is about my asthma partner.
Okay, so from your examination, what are the findings that suggestive of asthma?
Okay, examination, during admission, the child is alert, but only speaking in short sentences.
Okay.
He has warm peripheries, the good pulse volume, capillary refill time was less than 2 seconds, but he is tachypneic with an RR of 46, and there is Harrison sulcus. And notice it is hyperinflated. He has hyperinflated chest, and we check the nasal. Notice there is a left inferior nasal turbinate hypertrophy. And then the lungs wise, it's generalized bronchi with reduced air entry over the right side. So we thinking of asthma, doctor. So we started him on treatment.
Right. So what are the exacerbation factors this time around?
Okay, this time around, he has sick contact with his mother. So we think the trigger for this time is URTI. According to chest X-ray, there is perihilar haziness. So we thinking maybe viral pneumonia, and we said infarct.
Okay.
So infarct, it came out with rhinovirus, enterovirus detected.
Okay. So patient, the exacerbation, how bad was it? Moderate, mild, severe?
This time around, the exacerbation is severe with a pass score of 13.
Why say severe?
Okay, because his SpO2 unable to sustain under room air, it was just 94 under room air.
Okay.
This is 2 points. And then he has tachypneic with RR of 46.
Okay.
And also, he only speaking in short sentences, unable to speak in full sentence. And also, there is intercostal, subcostal, suprasternal recession.
Okay.
And lungs-wise, it's generalized bronchi with reduced air entry.
Okay. Sounds like moderate.
Moderate.
Not severe.
But memang total is 13 points.
Pass score. So they want the severity because of pass score rather than the asthma itself. So the asthma severity you say is having recession, SpO2 94, which is less than 95. That sounds still moderate.
Okay. Kalau less than 90 baru macam
less than 92 is severe lah. Okay, then speaking in sentences rather than words. Okay. Alright. I don't know, from your description sounds like moderate lah to me. Okay. Alright. I don't know whether they include the pass score inside or not. Okay. Okay, never mind. So what was done?
Upon ED is actually already past score 13.
Okay.
So they given MDI salbutamol 12 puff back to back 2 cycle together with MDI Berodual 4 puff back to back 1 cycle. After that, the child improved, so they admitted to us for monitoring. But upon admission, we noticed the pass score is still 13 with like worsening tachypneic and recession. So they loaded him with IV magnesium sulfate because they think severe. And then while awaiting loading, the child still in respiratory distress under face mask, so they started him on CPAP.
Okay, so on CPAP initially lah.
Yep.
So what are the signs of life-threatening asthma?
There will be hypoxic,
Okay.
cyanosis,
Okay.
and then we will there is silent chest,
Okay.
no breath, no air entry.
Alright.
And then
What gonna
the
happen?
child may be drowsy.
Okay. What's going to happen to the pulse rate if from the drowsiness? Is the hypoxia in a long time? What will happen to the heart rate?
Cause bradycardia.
Okay. Alright. Okay, so how do you want to give? How you manage asthma, acute asthma, the exacerbation?
How to manage? Firstly, we need to classify the grade of the exacerbation, and then according to exacerbation, different grade we treated differently.
Okay.
So for this case, severe asthma, I think at the first point, if we already classify as severe, we should give the MDI salbutamol back to back, 3 puff. If the child is conscious, not that drowsy.
Alright.
And then together with MDI Berodual back to back. And then if the child is
so you prefer MDI or prefer nebulizer?
If the oxygenation only nasoprom, maybe an MDI, but if I need higher oxygenation, then I prefer nebulizer.
Why?
Because nebulizer can give together with the oxygen.
Okay, so I think the main important here off point to give nebulizer is patient is hypoxic, don't give like MDI. Okay, hypoxic 92, 93, give oxygen lah, give net Okay, what can happen if patient already hypoxic, you put MDI?
You will get more hypoxic.
Yeah, because no oxygen, right? Okay, which is can happen. I seen it happen before. Okay, patient get small cyanosis after you put MDI because they already hypoxic in the first place. Okay, so what are the medication available that you can choose to treat asthma other than salbutamol?
Other than salbutamol, we can give atrovan.
Okay, atrovan is what?
Atrovan is ipradopin bromide, which is SAMA, short-acting muscarinic antagonist.
Okay. Alright, other than ipradopin bromide, what else available to give during acute attack?
We can give corticosteroid.
Can. What are the example?
It's either IV hydrocor when the child cannot tolerate orally.
So which one is superior, hydrocor or penicillin?
It actually has the same effect.
Okay, alright. Okay. So you already listed the first line already then? What are the second line, third line?
Second line can be IV Maxalf. But we need to watch out for hypotension.
Why?
Because IV Maxalf cause vasodilation.
Okay.
And then
so if I got hypotension, what you want to do?
I want to give fluid resusc.
Okay, alright.
And then any more?
Any more? Any more drugs you can give other than Maxalf?
IV salbutamol.
Can.
Persistent no improvement.
Some more? Anything else? At least one or two possible medication that you still can give.
Subcut terbutaline.
Yeah. Okay. Alright. So already finished all the medication. Patient still huffing and puffing. Still very bad. What else you can consider?
We consider the ventilation.
Okay. So what kind of ventilation you want to consider?
CPAP.
CPAP. Okay. So CPAP got what?
CPAP will have a continuous positive expiratory pressure.
Okay. So what is the name of the pressure?
PEEP. Positive and expiratory pressure.
Okay. So what does it do?
It open up the alveoli.
Okay. So I remember my teaching.
Yes.
Alright. Okay. So when patient already well, so when you want to counsel parent asthma education, how you want to tell the parent about asthma?
Okay. First of all, I need to tell what is asthma. So asthma basically is a chronic airway inflammation. And then when the child has trigger, then it might cause bronchial constriction. The bronchus will constrict. So knowing the airway already inflamed and constrict, then the child will develop all those wheezing, SOB, these things. So that's why we need to start on medication. So medication, we have two types. First is reliever, second is controller. So reliever is to open up the airway for the constricted airway. So normally it's just when there is trigger, then we give reliever. But another controller is to constantly giving to reduce the inflammation of the airway. So need to be compliant to the controller, and whenever needed to give the reliever.
Okay. So if my mother asks which one you have to take every day?
So the controller need to take every day. So we need to tell it's the orange color if it's a Flutica.
So if parents say, "Doctor, can I stop the medication myself?"
Cannot.
Why?
Because the corticosteroid need to take a few months for anti-inflammatory.
Okay. So mother asks, can my child take the MDI directly or not? Which one you prefer? Direct technique or
aero chamber, is it?
So why we prefer aero chamber?
We prefer aero chamber because it's more sealed, and then the child may don't have the technique to inhale the direct one.
Alright. So how you want to educate parent about aero chamber?
Aero chamber, there is a way to use. First of all, you need to confirm it's still no leaking.
Okay.
And then for each one puff, you can wait for the child to have 10 breaths. This is the technique of using it. And then technique of storage is also important.
Okay.
You need to keep it dry, and then to put in a container that is clean. And then the technique to wash it. So we suggest to wash every once a week, but not to wash the inner part of the aero chamber, because it may destroy the charges inside the aero chamber.
Okay, alright. So what are the possible factors that can contribute to poorly controlled asthma?
Or possible factors contribute.
Poorly controlled
Poorly
asthma.
controlled. First, I think, is it the 5C?
I don't know. What is 5C?
Incorrect diagnosis of asthma.
Okay, can. Some more?
And then incorrect technique of inhaler.
Can. Alright.
And then non-compliance to the inhaler.
Okay, alright.
And also there is continuous exposure to the triggers that they don't remove. And then lastly is...
What are the conditions that can also contribute to poorly controlled asthma?
Condition. When they not treated the allergic rhinitis.
Okay, some more?
The eczema as well.
No, eczema don't have to do anything with that.
Respiratory tract infection.
Okay.
Obesity.
Yes, obesity. Okay, so why obesity? Why obesity?
Because obesity child will have larger lung volume than the airway.
No, that's not the reason. The reason being is obesity is a state of inflammation. Okay, so you have inflammation everywhere, inflame your airway, inflame. Even though you give the steroid treatment, but you don't control the obesity, the inflammation don't really improve lah, despite the corticosteroid treatment. So if you have inflammation of the liver, what you call it?
Inflammation, liver hepatitis.
Yeah, so they can get fatty liver hepatitis related to obesity. Same also for the lung. Okay, that's why even they don't have family history of asthma, if the child is obese, and then suddenly they will get the attack lah. So because the airway is kind of inflamed, so when airway is inflamed, it's very hypersensitive lah. Okay,
which is relevant to this child.
Yeah, that's most likely relevant to him because you know the weight is about 40 kilos for 10 years old. 10 years old should be around 30 kilos lah. Okay, so it's 10 kilo over. Okay, so that's possible trigger the asthma suddenly get worse again. Then probably another reason the asthma very difficult to control, then they can get very bad exacerbation lah. So the factor not just treating the asthma using the medication, to control the other factors as well lah. So I'm sure they have treated the allergic rhinitis.
He is not that good in there.
Okay, so that's why we also get in the dietitian to come in as well, advise all this lifestyle thingy lah. Okay, alright. Okay lah kot, cukup lah. Dah.